Hello and welcome to the ESRD National Coordinating Center's Learning in Action Network. Today we are focused on transplantation. We have a very full speaker presentation and lots of great things to get through. So I'm going to keep the NCC comments short. We will be hearing from 3 networks today and multiple professionals. And for those of you Network 6, Rachel, your team is last. You can take it right up until 2 minutes before the close of the meeting to ensure that we have time to get through all of this. So I will get started. This meeting is being recorded. We do send out a link to this recording of this meeting after the event, should you have colleagues who are not able to attend today but who would like to. Everyone is muted. It ends up being a pretty big group once we get started. We will send out the materials, including this deck, following the presentation, usually the beginning of the next week. On the call today, we have dialysis and facility transplant professionals, certainly our ESRD network staff. CMS is on the line, and we also do invite patients and families to this call series. Key objectives for today are really just to talk about processes to track and trend the steps to transplant at the facility level, and really to empower facility staff to communicate about transplant. And certainly our professionals are going to go much deeper into these topics. As we think about, the reason we're here to get together today, it is to spread the best practices from this call. And so as you go through this, please listen and share, be as engaged as you're able to be. We are going to be using the chat feature. So in a moment, I'll prompt everyone to put something in there just to make sure that it is working. And then think about how you're going to share the information that you've heard today and commit to sharing that with at least one colleague in your organization. So we'd like to prime you with some questions to think about as we begin here. So these are our questions to run on. So the first one being, what aha concept might you hear today that you could introduce to your leadership? How might we use the change package to improve outcomes? And in what ways could you adapt and adopt this approach to increase and sustain improvements in transplant, waitlist, referral, and success? So again, we are going to get started here using the chat feature. So in the chat, please answer this question. Have you previously used the NCC's transplant change package? And make sure when you do that, you click to everyone so we can all see your input. Great, thank you so much. I see some folks using that. So as we move forward, we will be using chat for questions for our panelists. I'm probably going to hold off on most of them, but if you do have an easy yes/no question, you can pop it in chat and our panelists can attend to that as we move forward. So if you haven't seen the change packages, the ESRD NCC puts these out. We put updates out every year based on the top performers in those areas. So here's a sampling. We certainly have one for a change for our transplant. We are in the process of revising it and sending out the new edition later this year. And I will send links to that at the close of this presentation. And without further delay, I really want to get forward and move into the presentations. And so I will pass it to Ku from Network 4 to begin.
Thank you, Sarah. My name is Ku Kamor. I am with Network 4. I want to welcome Angela Garner. She will be sharing best practices using the transplant change package. Angela?
Thank you, Ku. Thanks for having me today. My name is Angela Garner, and I'm a social worker that works with Fresenius Kidney Care. I've been with the company for 13 years, and I'm currently covering 3 clinics in Allentown, Reading, and Kutztown. Today, I'll be presenting about dialysis centers and best practices for improving transplant goals. Next slide, please. So just to review again, if you haven't seen these change packages, the ESRD National Coordinating Center gathered information from high-performing dialysis facilities and created a change packet to help increase kidney transplantation. One of my clinics was selected for a brief pilot study by ESRD Network 4 to utilize this change packet and to track any improvements. During approximately the 4-month period of integrating this change packet, my clinic saw some notable improvement in increasing the total number of patients that were waitlisted. And I was actually very excited. I just printed out the current UNOS waitlist, and I saw that we have almost doubled our waitlist numbers from about a year ago. So I really can see that using this change packet is really helpful. So with this change packet, it highlights 5 primary drivers, which are goals, and multiple secondary drivers, which are actions that are used to increase kidney transplantation. So next slide, please. So I'm going to be going over some important terms. I'm sure all of you are very busy like I am as well, and I like to break things down even further. So primary drivers are really merely just the goals. You'll refer to this at times throughout this package. And then the secondary drivers are the interventions that impact the primary drivers. In other words, are the actions. Next slide. So this slide is actually from the Transplant Change package, and I really like this page because it helps to narrow down the precise goals and specific actions that can be taken to achieve these goals. So to the left, you'll see 5 specific categories or primary drivers or goals. To the right, you'll see multiple secondary drivers or actions that were taken to help achieve these goals. What I've done for today's presentation is to summarize these primary drivers and secondary drivers into 3 categories. I'll be discussing today best practices to create a pro-transplant culture for your dialysis team. I'll be discussing practices to create a pro-transplant culture for patients and their families. And then lastly, best practices to create a pro-transplant culture with transplant teams from multiple transplant programs. So if you could, next slide for me, please. Thank you. So let's start with best practices for creating a pro-transplant culture with your dialysis team. Engage your team. Get them on board with your missions and goals. A positive attitude and enthusiasm can really be infectious. So if you get your team excited about this and explain how this could possibly benefit the quality of life for your patients, it can really be helpful. Promote patient compassion from your team. If you spend time helping the staff to understand, again, the quality of life and also the barriers that some patients may face to getting transplant, it can help them to be more engaged. If your team is emotionally connected to the goal and it's actively involved with pursuing the goal, chances are they will be very much more engaged as a team to work on this together. Some effective ways that my clinic was able to do this is through discussions and daily team huddles. Discussions can include a review of transplant education, transplant-related updates, or goals for patients on each shift. In our team huddles, we also identify new transplant referrals, identify any patient barriers related to appointments or transplant follow-up, and we also make efforts to celebrate successes that our patients may have after they've completed some testing or attended any transplant-related appointments. Additionally, our clinic has also identified a transplant champion for each clinic. I'm not sure if you've heard of this term before, but it's really a staff that is willing to be the designated cheerleader for your transplant team. The roles of this person includes maintaining a transplant binder with all the referral information and any correspondence with transplant centers regarding specific patients. I make a point every week to go over this binder with a transplant champion, which has really been helpful to me since I'm covering 3 clinics. The transplant champion also assists in following up with patients regarding upcoming appointments, assists with referrals to transplant centers, and is a cheerleader for transplant education for patients and staff. And I can't emphasize enough how important this role is and has been for our clinic, especially if you're a social worker and you're covering multiple clinics. It really takes a team to help promote a pro culture of transplant. Lastly, your physicians and extenders are also an essential part of the team. Encourage them to be involved by understanding our goals, reviewing patient transplant-related updates and monthly lab review meetings, and encourage physicians and extenders to discuss transplant-related goals or barriers with patients during rounds. My physician extender actually is able to look up, and it's called EPIC. It's our local hospital systems. And in our lab review, we've made a practice to go over very specific up-to-date notes from the transplant team. And then I will also document that on my side as well. Next slide, please. So this is best practices to create a pro-transplant culture for patients and families and caregivers. We have already a lot of established ways that we present education to our patients and to families. And that, of course, traditionally is through discussions, feedback questions, and educational handouts. But we also need to remember to make education fun. One thing that we have done at my clinic, actually all 3 clinics, that has been really successful is we've come up with some trivia transplant games. We actually purchased a microphone that was cordless and a speaker, and we have walked around the clinics, either half the room at a time or the whole room at one time, or we've done this in the lobby, where we engage families, caregivers, and even the patients with trivia questions related to transplantation. We give them multiple choices so that it's not intimidating. And for correct answers, we have a little basket of prizes. I have collaborated with transplant programs in the past where they have either participated in person with these transplant trivia lobby days, and so have contributed little prizes to give to patients. That might be, transplant pens or pencils or bracelets, or sometimes we'll even purchase some little trinkets from the Dollar Tree. It's just something to make it fun. When you're having fun when you're learning, you usually retain the information more. We've also invited transplant patients back to speak in our lobby to other patients. Prior to the COVID days, they were able to go into the clinic, and now we are able to have them back into the lobby. But that's also been very helpful for patients to really buy into the transplant process, hear directly from somebody that has gone through this themselves. And it can also be very inspiring if a patient shares barriers that they faced and shared how they overcame those obstacles. Be sure to have bilingual staff or a language line available when you do your transplant lobby days or any of these games. It's important not to exclude anyone. Also, creating bulletin boards and languages spoken at your clinic. In my Reading clinic, we have about 5 different languages. So we've been really trying hard to make sure that we include those patients and their family members. Also, you can create bulletin boards that maybe have a timeline of how the transplant process works. I can't tell you how often, no matter how long the patient has been here or they've already been working with the transplant program, they often need these reminders of how this process works, because it's very often when they're overwhelmed, they get confused and they forget, what they have to do or what's next. So that's important. Next slide. So this is a really helpful tool. If you haven't seen this, you can find this on ESRD Network 3, 4, and 5 on their websites. I have this printed in some of my clinics, and what I'm planning to do in the future to help utilize this tool even more is utilize an iPad. And if you take an iPad and you scan the code that's there, you could actually individually give this to patients during their treatments, and they're able to listen to 10 different patients through their transplant journey. You can also show this to patients or family members that have a smartphone and can have this out in the lobby and encourage and facilitate patients and family members to explore this as well. Next slide. So this is about best practices to create a pro-transplant culture for your transplant teams. It's really important to establish a relationship with not just 1 or 2 transplant programs, but with multiple centers. I'm still working on this myself, and I find that as I continue to reach out and develop rapport with more and more teams, it's really been helpful to improve that communication. For our lobby education days, we reached out to various transplant programs, as I mentioned before, and I got a little daring and I reached out to the new chief of surgery at one of the transplant programs. And I was really surprised and honored that the chief of surgery actually came to our clinic and helped to do the lobby day. He met and greeted our patients, he answered questions, and then he also helped with a lunch and learn for our staff. It was really impactful to the patients because it took away a lot of their fear. Reaching out to them opened up a lot of doors that we may not have had before. The surgeon actually even invited our team, the technicians or nurses, social workers or dietitians, to reach out to them if they're interested in watching an actual transplant in the OR. So again, it's really important to know who your team players are and to continue to facilitate and strengthen that relationship with the teams. Also, keep your communication with the transplant teams bi-directional. It's so important that it's consistent and frequent. We've done this with emails and scheduled calls. Typically, before a patient is going to be seen by a transplant team and reviewed, I have now the social worker will call me or they'll email me and we'll discuss any issues or concerns prior to the meeting and then also sometimes afterwards as well. Reach out to your transplant teams to make them aware if a patient's having trouble navigating their transplant system. And also touch base with transplant team immediately or as soon as possible after a patient gets transplanted, just so you can follow up on the patient. Next slide. So in summary, what are the takeaways to begin making improvements with your transplant progress? Focus on the following: creating a pro-transplant culture for your team, because again, it is a team effort and you'll need everyone engaged. Encourage a pro-transplant atmosphere for patients and families through education, lobby days, and connecting them to other transplanted patients using visual aids and videos. And encourage a pro-transplant culture and strengthen communication with multiple transplant hospital programs. And have frequent and consistent contact with them. Invite them to participate in lobby education days when possible. Next slide. So how can we make these changes sustainable? If you ask yourself this, if you were able to have a newly hired employee join your team, how would you sustain this process to pass it on to new employees? The first point would be to be sure that you incorporate the transplant change packet into all your new staff orientation for all disciplines, and provide consistent transplant updates within the team daily huddles. You learn really valuable information that way. Again, the techs and nurses are often the eyes and ears on the floor, especially if you're in the social work role. So it's so important to collaborate with them because they may have an update that you had not heard yet. Share and review transplant and implementation strategies, barriers, and review of goals achieved and goals that are desired to be achieved in your team huddles and in your lab reviews and in quality meetings. Share the updated UNOS waitlist results in team huddle. I actually started posting this where in a confidential folder that the staff can see at the nurses station. And lastly, continue to engage Transplant Champion with helping to maintain a pro-transplant culture. Your Transplant Champion is a really important role and it's really helped us a lot. And then next slide. And that concludes my presentation today. I really hope that some of these ideas were helpful. I hope that if you have not used the transplant change package for transplant, that you take a look at it. Again, we found it very helpful. And if you have any questions, you can reach me at my email listed below, or feel free to reach out to Ku at her email as well. So thanks for having me.
Thank you, Angela. That was really well said and nicely organized. We are going to move to Network 5. It's actually Amanda Morelli today from the network to introduce her speaker, Nadine Graham.
Good afternoon. I'm thrilled to be introducing our speaker, Nadine Graham. Nadine's been a social worker for 15 years, the last 5 of which has been serving the patients at DaVita Glenside Dialysis. She works with patients of all levels and modalities, but is truly passionate about transplant as a treatment option. Nadine has not only had great success in transplant at Glenside, but also with home modalities. So with that, I will turn the presentation over to Nadine.
Thank you, Amanda. So I wanted to come to you guys and share some of my strategies here at Glenside Dialysis. So I wanted to share a little bit about our facility here. So if we can switch to the next slide. You know, Glenside, we are a great facility because we had the opportunity to provide dialysis at all levels of doing different treatment modalities. So we currently have 146 patients with 55 PD patients, 13 home hemo patients, and 78 patients that are in between in-center hemodialysis as well as our nocturnal. And I have the opportunity to work with all of the patients over at Glenside. And so we're an interesting place. We're a suburban type of facility. So we're close to the city, but a little bit far removed. So I just wanted to give an opportunity to share a little bit about what our facility looks like. Our patients at DaVita kind of range in age from early 20s to definitely the elderly, as well as having various different socioeconomic statuses. But I would say that most of our patients have Medicare primary, which is a factor, of course, as we think about transplant referral and going through that process, as well as private pay or a combination of the two, with some of our patients being Medicaid only, and that's something that we discuss prior to referral as well when we refer to transplant. Most of our home modality patients are independent, either working or they are retired. And that has been something that has also been helpful when we think about transplant as well. Our facility is comprised of about 53% individuals who are African American, 38% who are Caucasian, a smaller percent of Hispanic and of those of Asian descent. But most of our patients, as I mentioned before, about 96% do have insurance, with about 3 to 4% who are either undocumented or underinsured. So that's give you a little bit of an idea of what Glenside looks like as a whole with all of the modalities, and of course that's peritoneal dialysis, home hemo, nocturnal, and then our biggest is in-center. And so what that looks like is we have 60% of our patients have either been referred to transplant centers in our local area and have either been denied or they're of advanced age. And so we try to navigate what that looks like depending on the age for referral, but that's what that looks like. 16% of our patients are in currently workup. We have 12% that have been waitlisted active, 8% that are inactive, and of course that means that at some point in time they were active at some point, and for various reasons they're inactive, and we will navigate how to get them back active with the transplant centers as well. And then we have 5% currently that are referred, and they have typically haven't had their first appointment, is what that means for us. Can you move to the next slide? So my process and our process here at DaVita is that we truly as a team, from our dialysis techs to our doctors to everybody in between, believes that every patient should have the opportunity for transplant. Of course, there's going to be indicators where that may not be possible. Typically, that is due to those who are of advanced age and debility, as well as if they have an active cancer diagnosis that kind of keeps them in that process with going through their own treatment, that we respect and understand that the local transplant centers have their recommendations when we think about referring. So transplant, I'm very, very passionate about transplant, so I start that conversation about transplant as soon as the patient is admitted, typically in my initial assessment, which is around within 30 days. I am sitting with the patient and discussing, how did they get to dialysis in the first place? Because I want to have an idea of their understanding of what dialysis is, and what they have heard from their physician as to what their the goal of dialysis is. As we sometimes at our center have individuals who come in as an AKI. So in doing that, I understand their motivations, their interests, their barriers, and potentially the reservations that they may have with exploring transplant, because it's confusing. It's a lot going on when they're first admitted, but I want to start that conversation earlier so that it's a thought in their mind as we plant that seed and continue on with moving forward for transplant. So at that time, we have a conversation. Typically within that same time frame, the team comes together, myself, the doctor, our nurse practitioner, our dietitian, and we will discuss, you know, that patient, if the doctor is willing, based off of that person's health status, for referrals to transplant. And if it is a go, then, which I strongly encourage a go, unless I know that there's a barrier, and we talk about that as a team. Typically, the doctor will talk with me about what transplant center may be the best, depending on the person's health status, as we, in this area, are pretty fortunate to have quite a few transplant centers that are local, that are accessible to our patients. So after that discussion has already occurred, I will go back to the patient and I will share some more information and let them know, hey, you know, we're going to go ahead and move forward with referral. At that time, they've had a little bit of time to think about transplant, and we talk again, if there is barriers, I'm trying to figure out what their ambivalence is. Sometimes it's just truly fear about what are the next steps. Sometimes it has been based off of someone else who's been transplanted and maybe things didn't always go the way that they thought that they were. But one thing I try to impart on a lot of the patients is that this is their journey, and we can just start at day one with referral. And then I also provide information on what the transplant process looks like, whether that comes from our organizational information to the network to the actual local transplant centers that we are looking at referring. So we want to make sure that everybody as a team is talking with the patient. In our text, who see the patients more than I do sometimes, they are also in the process of encouraging or letting me know, you know, hey, such and such is really struggling with thinking about this process. I just wanted you to be aware of that so I can circle back. Can we go to the next slide? So we have gotten through the ambivalence, and we have sent the referral. And so typically during that referral process, as soon as I send out the referral, I have kind of an organized list in which we have our regular referral process, but then I keep another spreadsheet so that I know where the patient has been with each of the steps. And so education is ongoing all the way up into the first appointment. And so after referral, I make sure that I circle back to the patient and ask, you know, have you gotten a call from the transplant center? If I haven't received any correspondence, I'm lucky enough that I have had the opportunity to be on monthly calls and talk with our local transplant centers to get the information of when they have received the referral. So I know that that the patient is on their radar in terms of being able to get the first call. I inform the patient that let's talk to our family, because for that first visit, it's really important to have someone there with you to hear what is going on, just in case it's overwhelming. We talk about transportation to the transplant center. How are we going to get there? Who's going to go? And what they need to bring, if anything. After they have had the first visit, I circle back and talk with the patients to see if in that first visit they had questions. Did they feel like all of their questions were answered? Did they have any concerns? And kind of how they feel about the next steps, and if they actually know what the next steps are. Often they don't know the terminology and things like that in terms of what tests they may have, and we'll talk about what that looks like and the time frame and what to do in between having each testing, as it can be somewhat of a lengthy process depending on what's going on with the patient. In that referral process, I've had the opportunity to access the EPIC system for some of the transplant centers, so I'm able to correspond with the transplant center if there's any questions. We have had a transplant liaison that I've been able to work with, who also participates with making sure we get our patients from referral to activation, and we're able to do that with communicating with the transplant centers and getting information and finding out when the next appointments are, and me circling back to the patient to talk about how we're going to get there. Are we still interested? What are you afraid of? That type of thing. And then we also have that conversation about living donation and what that would look like, and how they can have conversations with family members or friends, or really anybody, about their story, because that can be a powerful piece in looking towards living donation. Next up. So I wanted to share a little bit of some successes that I've had over the past couple of years in terms of being able to work through the barriers. I had a very wonderful woman that I worked with, who was a 47-year-old Cambodian woman who had come to dialysis due to the complications from lupus. And of course, we know that those two chronic conditions kind of makes a lot of things difficult along the transplant process. So she had already been on dialysis for 2 years prior to me starting, and had been referred, and through working through the workup process with one of our local centers. And that was a pretty daunting task for her in general, because she was not a native English speaker, but could speak English at the elementary level, as well as kind of understanding different nuances of different things. So she could definitely correspond and talk with me, but when it came to certain cultural norms or information, she didn't always catch on. And I took that more so as a cultural barrier, not necessarily a cognitive deficit per se, because she could communicate with me about things that went on in her country. And, you know, I have a love of learning about different cultures. So we really were able to engage, and she was fully able to do that with me. However, as she would go to the transplant center, because her husband worked a lot, and she had 2 adult sons that were in different areas, there wasn't a lot of support on the home front. They knew what her goals were in terms of wanting to be transplanted, but they didn't really understand that it was a process. And so luckily she had a good church that she was a part of, with members who would take her to appointments and who were able to show up, but weren't necessarily able to commit to being the support post-transplant. And so in that time, that process, as she was working through workup, there were conversations with the transplant center and myself, as well as her, in which they were concerned about her ability post-transplant, if she were activated, to manage medications, because of feeling that she had some deficits, which she struggled a lot on the machine, and sometimes that would affect her overall. And then eventually she lost a good chunk of her vision, which put some barriers as well in that transplant process. So ultimately, the transplant center, this particular transplant center, did not feel that things would be appropriate for her, and so they did deny her, which was very, very depressing for her, as her goal was to ultimately be transplanted. That combined with feeling that her family didn't quite understand dialysis as a whole, along with feeling alone in the process because she struggled, with her symptoms post dialysis treatment, and there was an expectation from her family to handle a lot of the different household duties, and yet she just couldn't. So there was a lot of fear of being unable to be transplanted and disappointment. And we talked about that through encouragement and potentially exploring other options. As I mentioned, we have other transplant centers and locally that I felt, let's try something else. And so what we did, if you want to switch to the next slide, is we came together as a team, and I discussed with the doctor who was aware of why the transplant center had denied, and I really educated and let him know about what my thoughts were in terms of this particular patient and what was going on, and if there was buy-in, as there was support from the team, to refer the patient to another transplant center with some interventions in place. So we as a team identified that one of the biggest concerns was medications post-transplant. So we set her up with, prior to have medications pill-packed. We discussed with the spouse the importance of his support and understood that there was barriers with his job that kept him from taking her, and what we needed to do to kind of help, whether it was FMLA or trying to talk with the transplant center about really making sure we picked days that he could get off, and he was able to do that. She still continued to have support from her church, but definitely her family took a more active role in understanding that they had to be part of this process in order for her to continue through. And so with all of that going on, and me staying in contact with the coordinator that she had, she was able to move through that process and eventually get activated to the wait list with that transplant center. And ultimately, not too long after that, she was transplanted. So she had a total time of about 4 years on dialysis before she got transplanted, and she has maintained that graph. Next slide. Recently, I am so excited. We've had yet another barrier that I think may be affecting a lot of different transplant or dialysis centers in terms of transplant, and those are our individuals who are either undocumented or underinsured. And so I have been working with this gentleman, 42-year-old gentleman, who has been on dialysis for the past 4 years due to the inflammation or the damage to the filtering part of his kidney. So he has done well on dialysis overall because we identified that the nocturnal dialysis would be a good fit for him so that he would be able to work, as well as ensure that he got proper dialysis, because at that time we thought that this was going to be, and we're still not sure, but that this was going to be a long-standing dialysis treatment. And so it was recently that I became aware that one of our local transplant centers would explore working with individuals who were undocumented or more importantly, underinsured. And so what I did was I reached out to that transplant center's financial department to obtain the financial paperwork, as that was what I was told needed to happen. So me and this gentleman, we came together during his treatment, and I discussed, because he does speak English, but he reads in Spanish. So it's interesting. I have the paperwork in Spanish. We're speaking in English just so that he can read it. And I'm saying, what does it say? Because he knows what it says, but we're talking about what he needed to compile so that we could send in the packet. So we worked with that for a couple of weeks for him in order to compile all that information, and I submitted it and allowed time for the transplant financial department to review and ultimately let us know if it was some assistance and what type of assistance. And ultimately they were able to do that. And so this person has been able to be have an appointment with the transplant center coming up. Actually, it's just passed. So I'll do my normal system of going back and checking in. Next slide. So I'm happy to share that in 2022, our center has had 10 patients transplanted during that time frame. We are really excited, and we've had opportunities to talk to those folks. And so we're going to continue on with the same process, as well as adding some of the things I actually just heard today. Next slide. Thank you.
Great. Thank you, Nadine. I'll conclude there with your contact information. Another great presentation, excellent case studies. Again, very well organized and prepared. We're going to move to the last presentation today, and that is Network 6. I will introduce Caroline, who will introduce her speaking group. Caroline.
Thank you. I'm Caroline Sanner. I'm the Quality Improvement Assistant Director for the Network 6 service area. Next slide, please. Next slide again. Just for everyone's knowledge, Network 6 is comprised of North Carolina, South Carolina, and Georgia, and our demographics are on this slide deck. Next slide. So I'm going to introduce Dr. Rachel Patzer. She is the data chair for the Southeastern Kidney Transplant Coalition and also the president and CEO of the Regent Street Institute. Rachel, if you can take the floor.
Great. Yeah, thank you so much. And yeah, I was at Emory for about 18 years and just recently moved to Indiana. So I'm in the Network 9 region, but a lot of the work that I'll talk about today is I've started in Network 6 and then has expanded in the other IPRO regions. I think we also have Stephen Pastan, who's the medical director of our kidney transplant program that I believe he was going to try to join. I'm not sure if he was able to make it. And Jade Buford from our team who are also on the call. You can go to the next slide. So one of the things that really motivated us to first start looking at this problem was initially way back in 2010, our network had the lowest rates of kidney transplantation in the entire nation. We looked at data. This is showing the U.S. dialysis facility is the standardized transplant ratio, or the number of observed transplants over the number of expected transplants across the facilities. And we had just seen a lot of variation where there's some dialysis facilities that really had very few or no transplants in a year among their patient population, and some that had a lot more. You can go to the next slide. Though we've improved over time since our group, our coalition first formed, we still in Network 6, where our Southeastern Kidney Transplant Coalition is mostly focused, have fairly low rates of standardized transplant ratios across the all 18 network regions. You can see in orange the other IPRO network regions. So we have fair distribution where Network 6 is on the lower end, Network 9 is more so in the middle, though still under the national average, and Networks 1 and 2 are actually among the best in the nation. You can go to the next slide. So initially, as I alluded, we were ranked the last network in the nation in Network 6. And so this started really in 2010, really at the bequest of the ESRD Network 6 to form the Southeastern Kidney Transplant Coalition as a group of partners who all really cared about trying to improve access to kidney transplantation in our region. So you can see all the partners that are here. It included all of the transplant centers in that 3-state region of Georgia, North Carolina, and South Carolina, patients, patient family members, patient advocacy organizations like the National Kidney Foundation and American Association of Kidney Patients, and of course the ESRD networks, dialysis clinics and representatives, both large and small, DaVita, Fresenius, DCI, and others, and organ procurement organizations. And really our long-term goals were to really build this alliance of transplant centers, increase education and awareness about transplant, increase organ availability, and reduce racial disparities in access to transplant, which was a particular problem in our region in the Southeast. Next slide. And our coalition has done a number of different things, but I wanted to, I think for today, focus a little bit about some of the things that we've been doing with regard to collecting data on referral and evaluation for transplant that really started in Network 6 and has expanded to the other IPRO regions. And this is very early on. We recognized as we were trying to understand why did our region have the lowest rates of transplant in the nation, that we really struggled with, and I'm an epidemiologist, the data is always really important to me. And I really struggled that we really didn't have any information in national surveillance data where the yellow stars are. So when is a patient referred? When did they start the evaluation? And when did they complete an evaluation? So you can go to the next slide. That really was what motivated our RADIANT, or Reducing Disparities in Access to Kidney Transplantation, community regional expansion studies. And this has been really more than a decade of work where we have focused on collecting data on these steps that were not captured in the national surveillance data, and then doing interventions that tried to improve access and reduce inequities in access to transplant, including racial disparities in access to transplant among Black or African American patients compared to white patients. You can go to the next slide. And really, we're all focused. I know we don't have a ton of time, and I could talk for hours about all this work, but there's so much great content in today's call. Was really around something we put together and have been collecting data for over a decade. It's called the Early Steps to Transplant Access Registry, and this started again in Georgia with 2 transplant centers, and then it was all the transplant centers in Network 6, and now it's has expanded even more, as I'll talk about in a moment. But the goals of this are really to capture those steps on referral and evaluation. You can go to the next slide. So how we do this is we really work in partnership with our Network 6 and IPRO as the data coordinating center, and all of the transplant centers in our IPRO ESRD networks 1, 2, 6, and 9 have been invited to participate. Again, it started in Georgia, then moved to Georgia, North Carolina, South Carolina, and now includes more than 30 transplant centers in our network regions. And these transplant centers voluntarily participate and submit data to IPRO as the data coordinating center, and includes really just basic information to identify the patients, as well as the referral date and the evaluation start date and evaluation completion date. We then we have a research team that works with some of the de-identified data. IPRO, actually the data coordinating center, sends some of these data to the United States Renal Data System for linkage to the national surveillance data, so that we understand who's referred from our data source and who's not referred by the linkage. And then that final early steps of transplant access registry data is used for dashboards and interventions, as well as other quality improvement and research purposes. You can go to the next slide. So this really just describes this in a little bit more detail. And I think maybe for the interest of time, I'll skip this right now, just talking about sort of the quality of the data. But you can go to the next slide. So I alluded to this as well, that we have done a number of things with these data. One of these we call the Radiant Community Study, that we took some of these data and used this as an outcome to looking at the outcome of referral. Again, that data is not captured anywhere else, but because of the data collection that we had set up, we were able to implement an intervention that we really tied closely with the network's quality improvement project for the year as part of the CMS statement of work, and aligned what we were doing and some of the interventions with some of the resources that our Southeastern Kidney Transplant Coalition members had, and that the network had for selecting facilities to receive who were underperformers with respect to transplant access to receive an intervention. So we were able to randomize 134 dialysis facilities to really usual transplant education, or what we call our RADIANT intervention, which was transplant education and engagement activities targeting dialysis facilities staff, leadership like the medical directors, and patients. I won't go into all the detail about the intervention materials, but we can put in the chat, maybe I'll have Jade put in the chat, our website information that has a bit more information and some background for those that are interested. But our primary outcome, and this was at the dialysis facility level, was looking at the change in dialysis facility referral for kidney transplantation from referral to 12 months. And we also were interested in reduction in racial disparity in transplant. You can go to the next slide. So what we did was, oh, actually, I think that I missed those results, or I don't have the results in here for the very next slide, but that community study did find that we had actually reduced racial disparities and increased referral for transplant, nearly doubling referrals. So as I mentioned, another thing that we looked at just from the referral data was noting that there was just extreme variability in transplant referral rates across dialysis facilities. And I think one of the surprising things from this that we actually used as one of the interventions in the Radiant community study was just telling facilities what their referral rate was and how that compared to other dialysis facilities in the region. So for example, the median referral rate among new patients or incident patients within 1 year of dialysis start in the state of Georgia was about 24%. But there were a number of facilities, for example, there were 15 facilities that had 0 referrals over a period of time. And there were some facilities that had nearly 80% of their patients referred. So that was, one of the interventions that was part of Radiant was actually telling the facilities, giving them a feedback report that told them about their performance. You can go to the next slide. I know we don't have a ton of time to go into all this, but the Radiant regional study was really an expansion of that Georgia study, in which we expanded then some of the similar interventions that we found that worked in Georgia to Georgia, North Carolina, and South Carolina to a larger population. So we had 220 control facilities and 220 intervention facilities. We are still analyzing this data. One of the things we actually saw different results in this study, we saw declines in referrals, both among the intervention and control group. And that in part was, I believe, because of the change in the national kidney allocation policy that really has de-emphasized waitlisting. But we did find that Black patients were more likely to be referred compared to white patients, and that increased referral among Blacks was a bit higher in the 1-year intervention or 1-year follow-up. So we still have some data analysis and dissemination of findings that are ongoing for that study. You can go to the next slide. So as I mentioned, we have used some of these data to look at referral. We've also looked at evaluation start rates. This is showing some of the newer data that, or data that was published in 2017 on Georgia, North Carolina, and South Carolina that showed that on average evaluation start rates, median proportion of patients starting the eval within 6 months was about 16% of all patients. So you can see that there's certainly drop off. And I think though we have about, I showed in the Georgia data, about 25% of patients are referred out of all patients with end-stage kidney failure, only about 16% are evaluated among all patients with end-stage kidney failure, and that there's really significant variability. So that led to other studies and us expanding this data collection. You can go to the next slide. That just briefly shows that the more updated data collection on this, that we have seen after some of these interventions, we have seen increases overall. And this is, again, just Network 6, but for a lot of the interventions we've done that have focused on the Southeast and Network 6, general increases over time with percentage of patients referred and proportion of patients evaluated within 6 months. So the most recent data was 37.5% referred and 50% evaluated. You can go to the next slide, though there's still lots of variability as you can see across facilities. And then finally, I just wanted to talk a little bit, spend a few minutes talking about the expansion of this to all 4 networks. So we had some funding in 2019 that expanded data collection of referral and evaluation for all 4 ESRD network regions. And that includes 49 transplant centers and 1,850 dialysis facilities. You can go to the next slide. And one of the things that we're trying to do with this data, in addition to some epidemiologic analyses, is having an interactive dashboard for both transplant centers and dialysis facilities. In theory, clinicians or patients could use this. This is really just a beta version of this dashboard, and we're continuing to work on this. But centers that submit the data can log in and get specific center reports on their where they are doing with regard to referral, evaluation, start, and waitlisting. And you can look at this transplant center level or the network level. Not yet at the dialysis facility level, but I think this is still very helpful for dialysis facilities to be able to see, okay, well, if we're typically referring patients to, say, Emory Transplant Center, what does Emory Transplant Center, what might some of these centers look like, or the centers near me or in our region? And then comparing some of those statistics. And so if you go to the next slide, you can see a little bit of the data that's shown here. Right now, this is de-identified transplant center data. So the transplant centers, if they're submitting data, can log in and see which center is, or look at their own centers and see how they compare, with the intention really that those centers might say, okay, well, we see that we're on here and the proportion of patients referred to us is really low in comparison to, say, all the other centers. You can go to the next slide. This figure shows the proportion of patients that are referred within network 6 over time. Looks fairly consistent in this network. If you look at, and maybe Jade could put the link in the dashboard too for just the publicly available version of this so people could play around with it. You could look at from network to network what that looks like. You can go to the next slide. And other things that they can look at is what are the characteristics of patients who are referred or evaluated or listed across one network versus other networks. Here showing differences for patients that are referred, those proportion of patients across one network versus in network 6 versus other networks. You can go to the next slide. Oh, and this is by age. And then this is another graphic that you can look at within there, again, showing just from transplant center to transplant center, what proportion of patients are starting the evaluation within 6 months. So this is helpful. I think these are data, again, that are not available in national surveillance data. So transplant centers may be curious to know if you're a center that is on the lower end of the proportion starting their evaluation within 6 months, you might be curious to know what other centers are doing. And so ideally, this would be used to share best practices and to encourage more quality improvement to increase rates of referral and evaluation start, as well as listing. You can go to the next slide. Some of the other analyses that we have planned, and I don't think I have a ton of time to go into this, is but looking at data like racial differences in evaluation start within 6 months, we do see that there are differences across the networks. This is 1, 2, 6, and 9 in that order. And you can see that there are some differences by racial group. You can go to the next slide. I know we're almost out of time. But largely just to summarize it, we have more than 30 transplant centers participating. We are hoping these data, as they have been for the last 10 years, help inform quality improvement projects. Ideally, we have more, an ability to do this across the nation. I think that's something we've continued to advocate for, is that this would be great if we had more support to do this on a national level. We've seen a lot of value for our network 6 transplant centers, and soon hopefully more on the expansion. But because the disparities differ depending on the step that you're at, and there's various differences by region with certain inequities, we can't really do the best interventions without knowing the data and where those inequities are occurring. So the analysis is really intended to help identify what some of those regional barriers are to help inform interventions and improve access and reduce disparities. And then you can go to the last slide, I think next, which is just some of our contact information. And I know that was very fast, but I'm going to see if Dr. Pastan wants to chime in these last 2 minutes.
I'll just chime in. That was a great presentation, Rachel, and say that a lot of these data were collected from volunteers. The transplant centers are volunteers in getting together and giving us their data voluntarily for us to analyze, so that unless we have data on the early steps for transplant, we're not going to be able to define interventions to get people referred and through the evaluation and on the waiting list. And these are the really only data that are out there. So it's been a really exciting project. And also to thank iPro for their partnership in this project. They've been terrific over the last years.
Great. Thank you. Yeah, I agree. We definitely could not do this without iPro and the network. So and all the volunteers. So many transplant centers, I think, have just voluntarily done it. It's been great. So thank you.
Thank you again. Another excellent presentation. I think we've had a lot today. I know people are anxious perhaps to see the slide deck. We will be sending that out in the next few business days following this meeting. I'm going to run through, I just want to get to this slide. If you haven't been using the transplant change package, you can actually use your phone right now and scan this QR code and open it and save it or email it to yourself so you have a copy of it on hand. We will continue this series in quarterly, so the next transplant call will be in a few months, but please join us again for the NCC for another Learning and Action Network. We do appreciate your input and survey, so if you can, please fill out that survey at the close of this meeting. And again, thank you to all of the panelists and speakers today. It was excellent. Lots of information, lots of passion. Very thankful for everyone to have their time today, and have a great week and take care.